Okay, I'll start again. Bismillahirrahmanirrahim. Assalamualaikum and good morning. I would like to extend my warmest welcome to all of you for being here with us today, attending the half-a-day General Radiology Lecture Series webinar 2021. And this year, the theme of this course is Infection from Imaging Perspective Point of View. I would like to welcome also the eminent speakers from different walks of subspecialty, Dr. Salwa, Dr. Intan, Dr. Rahani, Dr. Melinda, Dr. Wendy, Dr. Erin, and Dr. Sarah. They are here to share their knowledge and experience with us. All the speakers, thank you for your time and effort. Okay, last year, we successfully conducted a one-day refresher course which focused on the basic anatomy from various subspecialty. We did hands-on ultrasound on Doppler carotids, and we conduct a written assessment related to the rectus. Earlier this year, in April and May, our in-house physicists, Cik Aswin and Cik Faiza, have greatly contributed to the success of the physics rounds teaching. The physics lectures in general radiology are well received by our MOs. However, due to our current situation, we are unable to conduct these courses in a physical manner. Okay. I would like to thank you, the Jawatan Kuasa Latihan, particularly Dr. Rasmina, our Madam Chairperson, and our HOD, for giving me the opportunity to coordinate this academic event. With the support of Jawatan Kuasa Latihan, Jabatan Radiology, we aim to conduct these courses on an annual basis with a focus on different themes. During this next few hours, you will learn about various topics related to infections. I hope the students are excited. Okay, learn as much as you can from our esteemed speakers. I encourage the student to be inquisitive. Do ask away any queries that you have in your mind. If you feel shy to share your beautiful voice, just type away your question. We will entertain and try to answer to our best ability. So before we get started, I would like to extend my heartiest appreciation to our amazing team for the full support, the commitment, great idea sharing to make this event a success. So I would like to thank the secretariats, Dr. Sarah, Dr. Rahani, Dr. Chiam, Dr. Victor, Dr. Wichia, Dr. Ashwin, and Cik Sharudin, Puan Wan Sharina, Puan Azmah, Puan Nohanisa, dan Cik Rahimi. Okay, we couldn't have done this without you. So on the last note, I am confident today will be fun and full of learning. Thank you very much. Wassalam.
Thank you, Dr. Kartika, our coordinator of the program. Thank you for your guidance. And without you, so we wouldn't be having this program. Next, we will have the officiating speech by none other than Dr. Rosmina binti Muhammad Qasim, our consultant radiologist and our new head of department, Radiology Department, Hospital Kuala Lumpur. We would like to welcome Dr. Rosmina to give the officiating speech.
Thank you, Dr. Victor. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. Alhamdulillah, we are here today in this webinar. More or less is actually knowledge sharing by our radiologists from our own department, Hospital Kuala Lumpur. I welcome all the speakers, I welcome all the participants who spend their morning to be with us, and I also welcome all the speakers from my own department, Radiology Department, Hospital Kuala Lumpur, to share their knowledge and skill and experience with us today. The theme for today's webinar is infectious disease, imaging perspective. As we know, infectious disease remain important cause of morbidity and mortality in Malaysia and the whole world. And imaging plays an important role in the diagnosis, management, and follow-up of these patients who have infectious disease. The imaging modalities almost involve all the modalities, not to forget our old friend plain radiography, ultrasound, CT scan, MRI, and even interventional radiology play a lot of role in this managing and diagnosing this patient. Therefore, we, as the person who involved in the imaging of this patient, we should keep our knowledge, the technology, the new findings in these diseases. And we must keep in mind that it is important to have the knowledge to deal with this infectious disease. And we have to continue learning. Even myself, probably the senior most in this webinar today, still continue learning. Even the disease, for example, tuberculosis, that we know that the disease already for centuries is already involved the humankind from very old days. But until now, we still need to learn about the disease itself, whether the disease clinical findings or the radiological findings. So, I just want to stress here, you cannot say that you already have all the knowledge to diagnose the disease. You still have a lot of room for the knowledge to be with you. And we must not forget, we also being tested with the new diseases. For example, COVID-19. We have not won the battle. It's still very active and still we don't know what's going to happen with the new strain, that is more dangerous. So we keep on learning. The knowledge that we learned 1 year ago probably is not that relevant now. So we have to continue learning. And we know this kind of infection, any kind of infection, most of the time it does not just involve single organ of the body. So we must not forget that infection can affect any organ in the body, including the skin. Therefore, we must keep ourselves open to all new knowledge, new technology. I want to stress that everyone needs to continue learning because learning is a lifelong process and continuous medical education is needed for us to keep us updated. We don't want to left behind without knowledge. Knowledge must remember the old, and everybody like to say that knowledge is power. We have to keep that in mind. Knowledge is power. Knowledge solves problem. Knowledge, inshallah, will continue and we need to continue. Inshallah, we plan to do knowledge sharing regularly, hopefully every year, and probably Dr. Kartika also and Dr. Nurul as well, who in charge of medical officer in the radiology department, wants to have regular teaching, whether in small groups or big groups, because we want to continue share knowledge with the young doctors and as well as others as well. Not so young also can learn. Before I end my speech, I would like to thank the organizing committee for all their hard work. I want to thank also all the speakers who are very keen to share their knowledge and experience. May Allah bless you all. And with that, Bismillahirrahmanirrahim, I rasmikan kursus ini. Thank you very much.
Thank you, Dr. Rosmina, for the very encouraging welcoming speech and officiating speech. We know that lifelong learning is actually important in development of any professional, and especially in radiology. I always believe that the eyes cannot see what the mind does not know. That applies particularly in our field of practice, which is radiology. So without further ado, we'll continue with our program of the day. The first lecture of the day is going to be given by Dr. Siti Salwa binti Muhammad Zaini. She is our fellow in neuroradiology from Hospital Kuala Lumpur. She obtained her medical degree from UPM and subsequently Master in Medicine of Radiology from University Science Malaysia. And the topic that she is going to share with us today is central nervous system infection. Without further ado, let's welcome Dr. Siti Salwa.
Assalamualaikum and good morning to everyone. I would like to thank all of you for attending our webinar today about CNS disease imaging. I'm Dr. Siti Salwa, one of the Neuro Fellow in HKL. And for today, I would like to talk about CNS infection. I will cover some of the most common type of infection that you may see in your daily work. Okay, so for introduction, the common etiologies for CNS infections are bacterial, viral, and parasitic infection. There is also other form of rare CNS infection such as fungal infection. Therefore, the knowledge of the common imaging patterns of this infection and the potential complication that may arise is critical in prompt and accurate diagnosis and treatment for the patient to reduce the adverse outcome. These are the form of intracranial infections. In meningitis, it is the most common form of CNS infection, and the infection will involving the meningeal lining of the brain. In cerebritis, it is a focal intraparenchymal infection without capsule or pus formation yet, and abscess is further progression of cerebritis with capsule formation. And encephalitis, it is a more diffuse infection of the brain, usually caused by virus. And for empyema, it is an abscess in enclosed or potential space in epidural or subdural region. First, I would like to talk about meningitis. It is the most common form of CNS infection. Meningitis is inflammation when it is involving the meninges covering the brain, which are either dura or arachnoid or pia mater. It can cause by bacterial, virus, TB, or fungal infection. As we can see from this diagram, these are the three layers of meninges. The most outer layer is dura mater, which can invaginate into the interhemorrhagic fissure, and in the middle is arachnoid, and the deepest layer is pia mater, which usually which is embedded into the brain parenchyma. So when the infection involving the arachnoid and pia mater, it will follow the cerebral sulci. The source of meningitis, hematogenous spread is the most common source, followed by direct spread from the adjacent infection, either by PNS or mastoid infection, or from extension of from adjacent brain infection from cerebritis or abscess. It also can occur secondary to post-surgical complication or from penetrating trauma. You have to bear in mind meningitis is a clinical diagnosis. Therefore, imaging in uncomplicated patient is most often normal. And role of imaging, usually we want to exclude other cause, the complication of the meningitis, as it can cause cerebral abscess, ventriculitis, or empyema. From this diagram, it shows when pleural exudate involving the leptomeningeal lining and filling the subarnoid space in the basal cistern and sulci. In this graphic, the greenish area is the area of purulent exudates within the cistern, and we can also appreciate here the adjacent brain appear hyperemic. There are two types of meningitis, and the more common one is the leptomeningeal type, when the inflammation occur at the subarnoid space involving the arachnoid and pia mater, and it can either be smooth or nodular meningeal enhancement. Usually smooth, we can see it in bacterial or viral meningitis, while nodular, we can see it in fungal infection. And for pachymeningeal, when the inflammation is involving the dura layer. This diagram shows on the left side is the how leptomeningeal enhancement will look like. The white area is the area of enhancement in the leptomeningeal, which it follow the pia surface of the brain and fill in the subarnoid spaces in the cistern in the sulci. On the right side is the contrast enhancivity. There's a leptomeningeal enhancement in the cerebellar folia. And this is pachymeningeal enhancement. It appears more smooth with no invagination into the sulci as compared to leptomeningeal, and it can extend into the interhemispheric fissure or in the tentorium cerebelli. In imaging, due to presence of exudates in the subarnoid spaces, it can obliterate the basal cistern and cause effacement of the sulci, and the exudate can appear as subtle hyperdensity within the subarnoid spaces. There's also we can see the area of cerebral edema and hydrocephalus caused by the meningitis. And in bone setting, we need to look carefully into if any evidence of sinusitis or automastoiditis that can be the source of the meningitis. In contrast, we can see area of meningeal enhancement in the sulci or in the basal cistern. And of course, MRI is more sensitive in detecting the meningeal enhancement and exudate in the subarnoid spaces. This is an image of a 25-year-old man with fever and headache. You can appreciate here the temporal horns appear dilated, and also the lateral and third ventricle mildly prominent, suggestive of hydrocephalus. And there's also presence of subtle hyperdensity within the suprasellar cistern, suggestive of exudates from the meningitis. This is same patient presented again 3 weeks later because of worsening of symptom. In this T2 sequence of MRI, it shows hyperintensity within the cistern, suggestive of exudate, with further dilatation of the ventricles. And in post-contrast, there is leptomeningeal enhancement in the suprasellar cistern and surrounding the midbrain, and also in the adjacent sulci, suggestive of meningitis with complicated with hydrocephalus. This is another example of meningeal enhancement, which involving the sulci in the inferior frontal region, in the basal cistern, surrounding the midbrain, with extension to the cerebral fissure. These are differential diagnosis of the meningeal enhancement. In leptomeningeal, it can caused by either non-infective cause, such as carcinomatous meningitis in patient with known malignancy, or non-infectious inflammatory disorders such as rheumatoid or SLE. For pachymeningeal, there are many other causes other than infection, such as post-op changes that we commonly encounter this, or can be secondary to intracranial hypotension, or can caused by either malignancy, metastasis, or granulomatous disease. This is an example of carcinomatous meningitis in patient with known lung carcinoma. We can appreciate here area of meningeal enhancement in the cerebellar folia. It will appear just similar as the infective cause of meningitis. Therefore, clinical correlation is very important. These are the complications of meningitis. The earliest and most common complication is hydrocephalus. It can either be communicating or non-communicating. The meningitis can further progress into adjacent brain parenchyma, causing cerebritis or abscess formation, and can extend into the adjacent subdural or epidural space, causing empyema or effusion. And it also can extend into ventricles, causing ventriculitis, and it is involving the choroid plexus, causing choroid plexitis. There is also cerebral vascular complication when the inflammation involving the vessel, causing vasculitis, which can further on may develop thrombosis or occlusion of the arteries and veins, causing cerebral infarction. So next is I will talk about tuberculosis. There are 3 forms of tuberculosis. The most common one is tuberculous meningitis, about 80%, followed by tuberculoma, about 30%, and abscess is the rarest form of TB. The common complication of TB, CNS TB, is hydrocephalus, followed by stroke. In tuberculous meningitis, when there is inflammatory exudate in the surrounding system causing meningitis, the appearance will be just same as the meningitis that I've explained earlier. However, the location will more common involving the basal system as compared to the superficial convexity sulci. In CT, the exudate will appear hyperdense and with bacillar meningeal enhancement. In MRI, the dirty CSF, the exudates, will appear hyperintense on flare with linear or nodular meningeal enhancement. So for this patient, it is a 6-month-old child with tuberculous meningitis. In this plain CT, it shows temporal dilatation of the lateral ventricle, and there is also dilatation of the 3rd and 4th ventricle with effacement of the sulci, suggestive of hydrocephalus. From this image also we can appreciate hyperdensity within the surrounding space in the basal system, suggestive of exudate. And in post-contrast study, there is a leptomeningeal enhancement in the basal system extending to the sylvian fissure and surrounding the midbrain. So this is tuberculous meningitis causing hydrocephalus. In this MRI image, this is a post-contrast study. It shows a diffuse leptomeningeal enhancement in the basal system surrounding the midbrain, extending to the sulci of both cerebral hemispheres with dilatation of the ventricles, in keeping with tuberculous meningitis with also hydrocephalus. From this graphic shows bacillar TB meningitis, and there's also presence of tuberculomas in the temporal lobes, which often coexist between the meningitis and tuberculomas. As we can note from this image, there is irregularity of the vessel, and due to inflammation caused by the exudates. And in the basal ganglia region, there is already area of infarction. This is one of the complications of TB meningitis that can cause a cerebral infarction. So this is another example of TB meningitis that can cause left basal ganglia infarction. As we noted here, from the contrast enhanced CT, there's a leptomeningeal enhancement in the area of left MCA region, and in flare MRI, there's hyperintensity of the basal ganglia. On the upper image is the DWI image, shows a restricted diffusion suggestive of acute infarction. So this is the TB meningitis causing the left basic ganglia infarction. So I proceed with next form of tuberculous CNS infection, which is tuberculoma. It is a focal parenchyma infection with central caseating necrosis. The location is anywhere in the brain, which can occur either in the cerebral hemisphere or basic ganglia, and also in the subarachnoid spaces. And majority of the tuberculomas are small in size, less than 2.5 mm. It also can appear as military nodules of few mm, and the size also can be big. We call as giant tuberculomas, which can reach about 4 to 6 centimeter. Tuberculoma can be either solitary or innumerable small military lesions. In CT, it can appear as either punctate or solid or ring-like enhancement, and in here granuloma, it can have calcification within it. In MRI, tuberculoma will appear hypointense on T1. It also will appear hypointense on T2 due to presence of central caseating necrotic material. And the liquefied area will appear hyperintense on T2. And there is no restriction on DWI in the solid caseating component. However, the liquefied area may restrict. So in this patient, we can appreciate leptomeningeal enhancement in the vessel system with rim enhancing lesion in the left temporal lobe with surrounding edema. There's also smaller rim enhancing lesion in the subarachnoid spaces. So this is the tuberculomas. In MRI contrast study, we can better appreciate other smaller rim enhancing lesion. This is tuberculomas with TB meningitis, which often coexist together. In this image, this is a T2 MRI sequence. The tuberculomas usually will appear hypointense on T2 with surrounding edema. And in post-contrast, it is rim enhancing lesion. And on this lesion, the there is a T2 hypointensity of the caseating necrotic material. There's also liquefied T2 hyperintense region within the same lesion, keeping with tuberculoma. So next is I will talk about cerebritis. It is a focal infection of the brain parenchyma. It can either by hematogenous spread or direct spread. If hematogenous spread, usually the lesion will be multifocal, and direct spread, the lesion will often focal. Bacteria is the most common cause, and if cerebritis left untreated, it can progress to focal brain abscess later on. In CT, the cerebritis will appear as area of focal region ill-defined hypodensity. Enhancement may be seen, but often ill-defined. And MRI, the finding will be similar. And in brain abscess, it is a progression of the focal region of cerebritis. The most common organism is the Streptococcus anaerobic bacteria or Staph aureus, and the source is just the same like cerebritis, either by direct from the PNS infection or surgical complication or trauma, or by hematogenous spread. It can either be solitary or multiple. If brain abscess rupture, it can lead to daughter abscess. There will be smaller lesions adjacent to the main abscess, we call as daughter abscess, or it can also rupture into the ventricle causing ventriculitis. And the most distinctive feature of abscess on imaging is the presence of smooth and thin capsule of the abscess. The medial wall of the abscess may be thinner compared to the lateral wall. As we can see in this image, the medial wall appears a bit thinner as compared to the lateral wall, attributed by the different capsule blood supply, but these changes are not consistently present and usually not specific. So in post-contrast study, we can the lesion is rim enhancing. This example of automastoiditis that causing abscess formation in the plain CT in bone setting. There's fluid density within the right mastoid cells and also in the right middle ear. In post-contrast CT, there's a presence of rim enhancing lesion of the adjacent temporal lobe. So the cause of the temporal lobe abscess likely secondary to the right automastoiditis. And this on the same patient, the T2 sequence, there is a rim hyperintense lesion with hypointense rim with enhancement of the rim in post-contrast with presence of restricted diffusion on DWI and ADC sequence suggestive of abscess. These are the complications of cerebral abscess. It can cause local mass effect, brain herniation, can cause hydrocephalus, or extension to the meningeal layer causing meningitis, and it can cause extra-axial fluid collection or empyema formation, and it can involve the adjacent venous sinus causing thrombosis, and the abscess also can rupture into ventricles, causing ventriculitis. These are the stages of abscess formation. There are 4 stages. The initial one, the cerebritis phase. There are 2 stages, early and late cerebritis within 1 week duration. And later on is early abscess or early capsule formation, around 10 to 13 days. And the final stage is mature abscess or late capsule formation that may last for several months. In early cerebritis changes, on plain the region will appear as ill-defined hypodensity. We can appreciate area of enhancement, and on MRI will be more restricted diffusion with patch enhancement or hemorrhage. And late cerebritis changes, there were evidence of thin irregular rim enhancement on this phase. And next phase is early abscess or early capsule formation. On this phase, the rim enhancer will appear more well-defined, thin, complete, and smooth with strong enhancement. And central necrotic area will be leucified and will with presence of restricted diffusion. On MRI, the T2 flare sequence, we can see double rim sign, which will appear as hyperintense inner with hypointense outer, as we can see in this image. The most inner layer of the wall will appear hyperintense, and the outer layer will appear as hypointense, we call as double rim sign. In post-contrast, there will be strong rim enhancement. And there will be also restricted diffusion on DWI and ADC. And the last stage of abscess formation is mature abscess or late capsule. With treatment, the capsule will appear more thickened and cavity will be collapsed, and the enhancement may persist for months, and the surrounding edema will be reduced. As we can note from this image, the rim appear more thickened and cavity is collapsed with lesser edema. And repeated image after completion of antibiotic in this patient after 6 weeks, there's a residual nodular enhancement of the abscess. This is the stage of the abscess formation. The early cerebritis, the area will be ill-defined hypodensity. In late cerebritis, we can appreciate area of enhancement with no organized capsule formation. In early capsule, we can start noted to see the rim enhancing, and the enhancement also more stronger. And this is a late capsule formation. This is one of the complications of abscess when the abscess ruptured into the adjacent ventricle causing ventriculitis. We can appreciate here there's the abscess located just at the periventricular region with defect of the abscess wall causing rupture into the ventricles, and the ventricular lining is enhancing with exudates seen within the ventricles. Abscess also can cause adjacent subdural empyema. As we can see in this patient, there is focal subdural collection adjacent to the abscess with restricted diffusion, suggestive of empyema. These are differential diagnosis of rim enhancing lesion. Sometimes we may have difficulty in differentiating between abscess and other primary brain tumors such as GBM or cystic or metastatic lesion or infarction, hematoma, demyelination or other type of infection. In GBM, the finding can be a rim enhancement. However, usually the wall will be more thicker and more irregular as compared to abscess. The wall will be smoother and more thinner. Next is ventriculitis. It is also known as ependymitis, pyocephalus, ventricular or ventricular empyema. The primary intraventricular abscess is rare because the more likely cause is secondary to rupture of brain abscess as I mentioned earlier, and others can be complication of meningitis or neurosurgical procedures such as from the EVD. In imaging, the ventricle will be dilated with layering of debris in the dependent part of ventricle, and there's also thin ependymal enhancement. In MRI, the layered debris can have a restricted diffusion and with thin ependymal lining. The ependymal enhancement we can differentiate with other cause, which such as CNS malignancy or METS, which will appear more thick and nodular enhancement of the ependymal lining. So for this patient, he has meningitis and adjacent brain abscess in the temporal lobe, which have ruptured the ventricles, causing enhancement of the ventricular lining with restricted diffusion of the debris within the ventricles. Next is empyemas. It is a rare but potentially life-threatening disease. It is pus collection either in subdural or epidural space. The cause can be either direct extension from the PNS or trauma or surgical procedure or hematogenous spread. And if left untreated, it may spread to adjacent brain causing cerebritis or abscess. There are two types, which is epidural or subdural empyema. Epidural usually will be focal, and subdural can spread diffusely along the hemisphere or into the tentorium or pores. In imaging, we need to look for evidence of CNS infection or ear infection. In epidural, usually will be focal and biconvex in appearance. It can cross midline. In subdural empyema, there will be crescentric appearance and may extend into the interhemispheric fissure. And in WI, can have a restricted diffusion with variable enhancement of the capsule. In this patient, he has a purulent frontal sinusitis, which have extended into the adjacent epidural space, causing epidural empyema. So this is another example of epidural empyema in the frontal region, secondary to the adjacent frontal sinusitis. And this is subdural empyema. Next is encephalitis. It is a diffuse infection of the brain, usually caused by virus. HSV1 is the more common cause, and this is other cause of encephalitis such as bacterial, fungal, or parasitic. It can happen in both immunocompetent and immunosuppressed individuals, and mortality rate is high, about 70%. This is a graphic image shows herpes encephalitis with bilateral asymmetric involvement of the temporal lobes, and also involving the cingulate gyri and bilateral insular region. This is the common location for herpes encephalitis. In imaging, it usually involving both cortical and subcortical region, often bilateral but asymmetric. But there is also case which involving the only one side. The pattern of edema is non-vascular distribution, so we can differentiate it with vascular infarction. And the second layer usually spread. It can also present of hemorrhage with patient enhancement and restricted diffusion. This is a patient with bilateral medial temporal region hyperintensity with also involvement of the bilateral insular cortex in herpes encephalitis. Next is neurocystic sarcosis. It is the most common parasitic CNS infection result from ingestion of ova of the tapeworm, Tinea solium, or contaminated fruits and vegetables. The larva will lodge within the CNS, and the lesion most often occur at the syrinx space, as we can see in the diagram here, in the syrinx space, in the gray white matter junction, and also can occur in the ventricles. Patient often present with acutely with seizures and headache. These are the stages of the neurocystic sarcosis. There are 4 stages, and the initial stage is vesicular stage. When the larva still viable, it appears as non-enhancing cystic lesion with a muronodule. The muronodule representing the scolex, and there is no significant surrounding edema. And the next stage is colloidal stage. When the larva start to dying, it appears as ring enhancing cyst with marked and moderate surrounding edema. And the next stage is granular stage. It is a healing stage when the cyst start to involute and the ring appear thick, enhancing ring with reduction of the surrounding edema. And the last stage is nodular stage. It is a heal stage, and when the lesion start to calcify with no area of enhancement or edema. This is an example of neurocystic sarcosis. In this plain CT, we can see there are many small calcified lesions in the gray white matter junction. And in MRI of the same patient, in post-contrast study, we can see there is a small enhancing lesion. These are different stage of neurocystic sarcosis in one patient when he have calcified stage and also the colloidal stage. So the last infection that I will talk today is toxoplasmosis. It is a parasitic infection by Toxoplasma gondii. It is the most common CNS infection in HIV and AIDS patient, and the common site is in the basal ganglia or cortical medullary junction, thalamus, and cerebellum. And it can manifest by meningoencephalitis or as granuloma. In imaging, it will appear as area of low density region with rim enhancement. The enhancement can be either nodular or ring, and there's eccentric target sign when the rim enhancement with small eccentric nodule representing the collection of the concentric vessel. Patient, he's 33 years old of HIV positive, presented with altered Manchester first. In the plain CT study, there is area of ill-defined hypodensity in the basal ganglia. Extending to the frontal region, and they proceed with MRI study. In the contrast sequence, within the area of hypodensity, there are multiple rim enhancing lesion, and the frontal lesion showing the classic target sign with a peripheral rim of enhancement. So this is a toxoplasmosis. Okay, another example, 36 years old male known to have HIV, presented with right facial droop. On plain CT, there's again area of ill-defined hypodensity in left basal ganglia. In post-contrast, the area there's a presence of irregular rim enhancing lesion. In post-contrast MRI, there is presence of eccentric target sign in this patient, which is the special characteristic for toxoplasmosis. Okay, that's all for my presentation. I covered some of the most common CNS infection that you may encounter during your daily work, and it is important to identify the different types of infection with the possible complication that may help in further management of the patient. Okay, see you again. Bye.
Thank you very much, Dr. Salwa. So we have entered the Q&A session. Due to time constraint, and we actually have two questions in the chat box. The first question is, Dr. Salwa, is there any features to differentiate between tuberculoma and cerebral abscess or small abscesses? Question is about Hajar.
Okay. Okay. Morning. Thank you for the question. About the first question, differentiating between tuberculoma and cerebral abscess. First is by location. Both tuberculoma and abscess can located in the brain parenchyma, intraparenchyma, but tuberculoma also can located in the subarachnoid spaces as compared to the cerebral abscess. In CT, by appearance, both of them will appear the same. Both can have rim enhancement or nodular enhancement if it's small. And the way that we can differentiate them by MRI, because content of tuberculoma is caseating necrotic content. So in MRI, the T2 usually will appear hypo-intense rather than hyper-intense in cerebral abscess. And in MRI also, in DWI sequence, tuberculoma usually no restricted diffusion that we can appreciate. But in abscess, there will be usually present of restricted diffusion if it is a pyogenic cause of the cerebral abscess. And that's the way we can differentiate it. If present of T2 hyperintensity lesion in MRI with rim enhancement, we can confidently say this is a tuberculoma. But you have to bear in mind, CNS TB can also later on develop tuberculous abscess. So in TB abscess, the appearance will be just the same, can be just the same like pyogenic abscess appearance on MRI.
Okay, Dr. I think we can go on with another questions. The next question is, Dr. Salwa, is it important to mention about the stages of tuberculoma in our MR report? By Corisa.
Okay. In MRI, if there is a presence of meningeal enhancement with concomitant tuberculomas, then we can confidently say this is CNS TB. And for the stages of tuberculoma, if the content because of the content of caseating and necrotic compound. So when you saw just like for if T2 hyperintensity with rim enhancement, we can just say it is CNS TB by appearance of tuberculoma. And if in here tuberculoma, it will appear as calcified lesion. So you can conclude as calcified granuloma in your report.
Okay, Dr. Salwa, so far these are the two questions that were listed in the chat box, and thank you very much.
Thank you.
Thank you for the answers. We'll go on with the